Ventricular tachycardia. Etiological types. Etiological types of VT. 1. Idiopathic VT. 2. Channelopathies associated with VT. 3. Organic heart disease associated with VT. 4. Drug-induced VT. 5. Traumatic VT, Commotio cordis. Idiopathic VT. Idiopathic VT occurs in 10% of cases. Absence of structural heart disease is usually suggested if ECG, except in Brugada and long QT syndromes, echocardiogram and coronary arteriogram are normal. However, structural abnormalities, identified by cardiac magnetic resonance imaging, and focal dysautonomia, have been reported in such patients. Idiopathic VT may be classified as focal or reentrant, right ventricular, left BBB-like pattern, or left ventricular, right BBB-like pattern, tachycardia. Adenosine-sensitive, outflow tract VT, Verapamil-sensitive, fascicular VT, or propranolol-sensitive VT. Adenosine-sensitive VT. Adenosine-sensitive VT is a form of focal VT, and represents 70% of idiopathic VT. It is thought to be caused by cyclic CMP-mediated delayed after depolarizations. It most commonly arises from right ventricular outflow tract, RVOT, showing left BBB-like pattern, but may also arise from left ventricular outflow tract, LVOT, showing right BBB-like pattern. Course is benign, prognosis is excellent, and sudden cardiac death is rare. Spontaneous remission may occur. Idiopathic VT from RVOT. ECG usually shows left BBB-like pattern, very positive QRS voltage in inferior leads, and dominantly negative QRS in both AVR and AVL leads. May present as repetitive monomorphic VT, with frequent premature ventricular contractions, couplets, salvos, and non-sustained VT, interrupted by brief periods of sinus rhythm. Sustained episodes of VT, precipitated by exercise or emotional stress, may also occur. VT with left BBB-like pattern are detected in 1. Structurally normal heart, focal VT from RVOT. 2. Structurally abnormal heart, such as arrhythmogenic right ventricular dysplasia and right ventricular fatty or sarcoid infiltration. Channelopathies. 1. Long QT syndrome. 2. Short QT syndrome. 3. Brugada syndrome. 4. Catecholamine-mediated polymorphic VT, CMP-VT. Long QT interval syndrome, LQTS. The congenital long QT interval syndrome is present persistently from childhood. It is characterized by prolonged cellular repolarization, resulting in long QT intervals, and/or prominent U waves. Patients are prone to episodes of torsades de pointes, which may cause transient lightheadedness, syncope, or sudden cardiac death. The arrhythmia may occur at rest, under emotional stress, or with exercise. There are two genetic patterns of long QT syndrome. 1. Romano-Ward syndrome, which is autosomal dominant, and is far more common. 2. Jervell-Nielsen syndrome, which is autosomal recessive, associated with congenital deafness, and is less common. Molecular basis of LQTS. Congenital long QT interval syndrome has been considered a consequence of abnormal patterns of cardiac autonomic neural innervation, since it could be treated with beta blockers, or surgical ablation of the left stellate ganglion. Progress in the molecular genetics, however, has clearly demonstrated that inherited defects in membrane ion channel molecular structure and function underlie the disease. Genetic mutations in LQTS. At least 12 mutations were identified, but the commonest are long QT1, associated with a decreased outward potassium current. Long QT2, associated with a similar abnormal current like type 1. Long QT3, associated with increased inward sodium current. Clinical and ECG criteria. Long QT1, broad-based T waves during sinus rhythm, and exercise-induced arrhythmia, particularly during swimming. Long QT2, low amplitude or notched T waves during sinus rhythm, and arrhythmia induced by auditory triggers, such as sudden loud sounds, like alarm clocks, or by strong emotions. Long QT3, long isoelectric ST segment during sinus rhythm, and arrhythmia during sleep. ECG during sinus rhythm. Long QT1, broad-based T waves. Long QT2, low amplitude or notched T waves. Long QT3, long isoelectric ST segment. Short QT syndrome. Short QT interval is defined as QT interval shorter than 300 millisecond, which does not change significantly with heart rate changes. Short QT syndrome is characterized by gain-of-function mutations of potassium or calcium channels. Golub score is generally used to specify the diagnostic criteria of this syndrome. Brugada syndrome. The Brugada syndrome is an autosomal dominant genetic disease, with male predominance, characterized by abnormal ECG findings and increased risk of sudden cardiac death. It is also known as sudden unexpected death syndrome, and is one of the most common causes of sudden death in young men without known underlying cardiac disease. Genetic basis of Brugada syndrome. Approximately 20% of the cases of Brugada syndrome are associated with loss-of-function mutations in sodium channels, SCN5A gene located on the short arm of chromosome 3. The genetic mutations may lead to dispersion of repolarization, which causes ST segment elevation, and facilitates the development of phase II reentrant extrasystole, that may precipitate ventricular tachycardia or fibrillation, often resulting in sudden cardiac death. Detailed necropsy studies have shown a structural right ventricular pathology, underlying the syndrome. 3 ECG types of Brugada syndrome are described. ECG changes are seen in leads V1 through V3. In all types there is right BBB-like pattern. In type 1, J-point elevation of 2 mm or more, coved gradually descending ST segment, and negative T wave. In type 2, J-point elevation of 2 mm or more, saddleback pattern of ST segment, and positive or biphasic T wave. In type 3, J-point elevation less than 2 mm, saddleback pattern of ST segment, and positive T wave. Brugada type 1. J-point elevation 2 mm or more. Coved gradually descending ST. Negative T wave. Brugada type 2. J-point elevation 2 mm or more. Saddleback ST. Positive or biphasic T wave. Brugada type 3. J-point elevation less than 2 mm. Saddleback ST. Positive T wave. Fluctuations in ECG changes. ECG changes can fluctuate over time. ST elevation increases with vagal stimulation. Antiarrhythmic drugs of class 1A, 1C, and 3. Fever. ST elevation, on the other hand, decreases with adrenergic stimulation. Exercise may decrease or increase ST elevation, probably depending on the autonomic balance. Catecholamine and metabolically mediated VT. In a limited number of patients, sustained VT appears to be mediated by catecholamines or other neurophysiologic influences, and commonly induced by physical or emotional stress. VT in these patients may be suppressed and subsequently prevented by beta blockers. A heterogeneous group of these patients have sustained VT that may respond to specific mediators, including Verapamil-sensitive and Adenosine-sensitive VT. Catecholamine-mediated VT is common in adolescence and can present with syncope, or even sudden death. It is usually familial but can also present as de novo mutations. Triggers include emotions and physical stress. Genetic patterns. 2 genetic patterns are described for catecholamine-mediated arrhythmia, autosomal dominant and autosomal recessive. VT in the structurally abnormal heart. VT may be associated with coronary artery disease, dilated cardiomyopathy, hypertrophic cardiomyopathy, muscular dystrophy, congenital heart disease, arrhythmogenic right ventricular dysplasia, inflammatory conditions, coronary congenital anomalies. Ischemic ventricular tachycardia, VT, and ventricular fibrillation, VF. Etiology and pathophysiology includes alteration of action potentials, prolongation of refractoriness, uncoupling cell-to-cell impulse propagation, alteration of the biochemical milieu, ion concentrations, acid-base balance, etc. The mixture of ischemic tissue and infarction regions provides the substrate for reentry. VT in the setting of acute ischemia or infarction tends to be polymorphic. Ischemic polymorphic VT may be associated with normal or slightly prolonged QT interval. VT in the setting of old myocardial infarction or scar tends to be monomorphic. Predictors of arrhythmic sudden cardiac death. Left ventricular ejection fraction is the single most important predictor. Other proposed predictors are syncope, abnormal signal averaged ECG, impaired heart rate variability, abnormal EPS, and T-wave alternans. Accelerated idioventricular rhythm. This rhythm is considered a form of VT, seen almost exclusively in ischemic heart disease, particularly during a myocardial infarction, and especially after reperfusion of an occluded artery. It is rarely seen with digitalis toxicity or in otherwise healthy persons. Mechanism is most likely enhanced automaticity. ECG in accelerated idioventricular rhythm shows wide QRS complex. Rhythm is regular or slightly irregular. Rate is 60 to 100 per minute. AV dissociation is often present, with fusion and capture beats. VT in congenital heart disease. Sudden cardiac death due to VT or VF has been reported in patients with tetralogy of Fallot. VT and VF usually arise in the right ventricular outflow tract, at the site of repair. Risk of VT and sudden cardiac death has been associated with a QRS width of 180 millisecond or more, the rate of increase in QRS width, and the severity of post-repair residual pulmonary regurgitation. In mitral valve prolapse, ventricular arrhythmia is common, but this disease is uncommonly linked with sudden cardiac death. Arrhythmogenic right ventricular dysplasia. This disease is a form of cardiomyopathy, characterized by replacement of the cardiac muscle by adipose and fibrous tissue, causing dilatation and contractile dysfunction. It begins in the right ventricle, but may progress to the ventricular septum and the left ventricle. It may occur sporadically or in families, although the inheritance pattern is unknown. Symptoms may include fatigue, atypical chest pain, syncope, or acute coronary syndrome. It may progress and can present differently, according to the time of presentation, while some patients may remain stable for several decades. Arrhythmia in arrhythmogenic right ventricular dysplasia. VT occurs in about 50%. Supraventricular tachyarrhythmia occurs in about 25%, such as atrial tachycardia, atrial fibrillation, and atrial flutter. Sudden cardiac death can be the first presentation. Patients at increased risk for sudden cardiac death, in arrhythmogenic right ventricular dysplasia. Younger patients. Recurrent syncope. Survivors of sudden cardiac arrest. VT with hemodynamic compromise. Left ventricular involvement. Increase in QRS dispersion greater than or equal to 40 millisecond. Naxos disease, arrhythmogenic right ventricular dysplasia with peculiar hair and skin manifestations. ECG features in arrhythmogenic right ventricular dysplasia. Before age 6 years, ECG is normal in about 50%. By 6 years, almost all patients have one or more ECG findings during sinus rhythm, depending on the degree of involvement, including epsilon wave, T-wave inversion, right BBB pattern, with QRS duration of 110 millisecond or greater in V1 through V3. Epsilon wave. This is a low-amplitude wave seen in V1 through V3 leads, caused by delayed activation of some right ventricular portions. It is considered a major diagnostic criterion, of high specificity but low sensitivity. VT in arrhythmogenic right ventricular dysplasia is seen in ECG like that of right ventricular outflow tract VT, discussed earlier. VT in inflammatory and infiltrative conditions. Several inflammatory and infiltrative diseases are associated with VT, such as acute myocarditis, sarcoidosis, and Chagas disease, Trypanosoma cruzi infection. Coronary congenital anomalies. These anomalies are associated with sudden cardiac death and exercise-induced death in the young. Correction of anomalies is recommended in symptomatic patients, but controversial in the asymptomatic. Drug-induced VT. Drugs associated with monomorphic VT include digitalis, epinephrine, Class 1 and Class 3 antiarrhythmic drugs, nicotine, cocaine, tricyclic antidepressants, phenothiazines, alcohol, inhaled glue. The polymorphic VT. Compared to the monomorphic rhythms, the polymorphic ventricular tachycardias, including the specific variant referred to as Torsades de points, tend to be electrically unstable, with higher risks for spontaneous degeneration to ventricular fibrillation, tend to have faster rates, and higher likelihood of syncope due to reduced cardiac output. They do not generally persist as long as the monomorphic tachycardias, either spontaneously reverting to a normal rhythm, degenerating to fibrillation, or triggering a monomorphic VT. Torsade de points. Torsade de points, a French name meaning twisting of the points, is a type of polymorphic VT, associated with delayed myocardial repolarization, most often manifested as prolonged QT interval. The peaks of QRS complexes seem to twist around the baseline. The rhythm is usually irregular. It is usually initiated with a short-long-short sequence. It is usually predisposed to by congenital or acquired QT interval prolongation, but it may occur without QT prolongation. The tachycardia rate varies between 150 and 300 per minute. Episodes of tachycardia may be non-sustained or sustained, and may degenerate into ventricular fibrillation. Torsade de points is shown in this diagram. Etiology of torsade de points. Congenital long QT syndromes. Drug-induced, the most common. Cardiac causes: infarction, ischemia, myocarditis, severe heart failure, mitral valve prolapse. Systemic causes: electrolyte imbalance, hypothyroidism, cerebrovascular accidents, starvation diets, organophosphorus poisoning. Commotio cordis. Commotio cordis is a sudden ventricular arrhythmia secondary to a blunt non-penetrating precordial trauma, as occurs in healthy persons during participation in sports. Ventricular tachycardia or fibrillation usually occurs if the blow falls in the vulnerable period 10 to 30 milliseconds just prior to the peak of the T wave, and usually results in sudden death. Thank you.